Welcome back, everybody, at Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim, and got my usual crew here who I'm remembering to I'll introduce you at least this time. One time you forget to introduce everybody, and they never let it go. So got Caleb Ferroni here to my left, Ray Pace here to my right, and our guest of honor this afternoon is Rob Flannery, Dr. Rob Flannery from the Sports Medicine Institute. So welcome.
Drusinsky Sports Medicine Institute.
Drusinsky. I got to throw that in there?
You got to throw that in there now.
Yeah. I probably would. I'm glad you said it because I wouldn't have gotten the pronunciation right. So that was my way to make you say it. So.
Appreciate it.
But hey, welcome, and we're intentionally airing this to begin the 23 football and sports season, and we recorded this obviously ahead of time, and we're airing this in August specifically for that. So I guess let's talk a bit about first about you. How does 1A become a doctor, and then connect that with sports? Was that just always played sports as a kid, and you wanted to merge those two loves, or how did all that come to be?
No, I mean, it was something that really I probably didn't figure out until a couple of years into residency. Yeah. I started out in general surgery.
Really?
Because I had always equated sports medicine with the orthopedic side.
Sure.
And orthopedic surgery, and it just wasn't something that was for me. And so I found out while I was doing general surgery that there was this other path where you could take and do primary care sports medicine. And so we would do physicals, pre-participation physicals for some of the high schools in the Baltimore area, and kind of learned a little bit about it, realized that my graduation date wasn't going to change, so I switched from general surgery to family medicine, specifically to do primary care sports medicine.
Just to stay in.
Kind of snuck in that way. So it was, I mean, obviously I'd played sports all my life and enjoyed sports, watching them, being part of them, and so to be able to kind of mix those two together, I'm lucky I don't take call. My call is standing on the sidelines for high school, professional, youth sports all the way up. And so not a bad seat in the house, and I will take a couple hours on a Friday night at a stadium, or a Saturday at a wrestling match or basketball game or soccer game, over being in the emergency room any day of the week.
That or being on call.
Exactly. Having to come
25 hours a day. Yeah.
Exactly. So I will take that well over anything else. Yeah, and so then the sports medicine, side, as far as getting into the emergency action plans and that side of it, that came from where I did my fellowship. I did my fellowship at Rutgers. I was there 2 years after Eric LeGrand, and if you remember, Eric was injured on a kickoff return. Neutral site kind of showed some of the deficiencies as far as the pregame meetings and things like that, as it was a neutral site, and his outcome was his outcome. It wasn't really going to change, but it highlighted, hey, we could have done this better, differently, or we could have done this better, or we could have known what our roles were beforehand. And so my fellowship director, kind of my mentor, Dr. Monaco, really kind of pushed on us, hey, whenever you get where you're going, get all the stakeholders together.
Focus on this,
figure out how to do it, talk about the different things that we're going to talk about later, as far as who's doing what when, and how are we going to move this athlete, and where are we going to take them. And kind of in the course of doing that, you realize that there are some knowledge gaps there, that if we can kind of bring people together and close those gaps, that's what we need to do so that the athletes have the best possible outcome.
Yeah, and that wasn't all that long ago, so we're talking about a rather young concept altogether, which is seemingly on its face like it should have been talked about long before. But yeah, I mean, we're not talking 10 years, right? Less than that.
Yeah, no. So it's probably been 10, 12 years now. It was. I did my fellowship in 2012, 13, and so it was 2 years. So it was 2011, 2012 in there.
Cool. So the sports medicine thing, you kind of touched on this. At the Institute, I'm not going to try to pronounce it. At Drusinsky, other than the the pre-sports physicals and stuff like that, what other services does all that offer, and what does the rest of the team look like behind you as a primary care?
Yeah, and so there's two different ways to get into sports medicine. You either take the surgical side or you take the primary care side. Primary care encompasses a bunch of different specialties. And so from the primary care side, you can be pediatrics, you can be physical medicine and rehab, emergency medicine, internal medicine, and then family medicine. Those are kind of the traditional, with family medicine kind of developing the sports medicine, the primary care sports medicine model. We take care of the non-operative orthopedics in addition to concussions, heat illness, disordered eating, some of the psychologic side of it. And so it really kind of encompasses anything that an athlete could deal with that is not a musculoskeletal injury. So whether it's performance, whether it's breathing issues, exercise-induced bronchospasm. I mean, you can kind of go down the list of what we deal with and making sure that the athletes are safe to be out there. And if they do get injured or they have an issue, that when we do get them back there, we get them back as quickly and as safely as possible.
To recovery. So that's interesting. The behavioral and the behavioral disorder, eating and whatnot. Wouldn't have been something I would have thought of being part of that, but yeah. No, you have a really wide swath there of things to take care of. I really hadn't wrapped my head around that. So, why is all of the who do you focus on? I think is the other part here is this just exclusively for top pro athletes? I mean, I know that UH of course works with the Browns and we have that section, but who are we talking about here?
Yeah, I mean, it could be anybody. And so when we talk about, the professional athletes, it's not just the Browns. We work with the Cleveland Monsters and we work with the Cleveland Ballet. So you can take into consideration Playhouse Square. You're talking about, top level theatrics and artists. So it's that all the way down to the Pee-wee level. So you take whatever profession that is and take it all the way down to the youth level. We deal with all of that, right? And so we take care of all the way down to Pee-wee hockey, Pee-wee football. You're talking about AAU basketball teams, to high school sports, to colleges. We have 7 colleges that we take care of now, over 60 high schools, in addition to those professional teams. So it's really grown a lot. Sports medicine keeps evolving and expanding. We try to make sure that as primary care sports medicine that we are taking care of the whole athlete and the whole team. It gets difficult sometimes when you're looking at what's in the best interest of the athlete versus the best interest of the team.
Sure. Yeah.
And so sometimes those two things don't line up. You try to get them to line up as best as possible. Having that open line of communication with coaches and athletic trainers, and so you want to get all the stakeholders together in addition to making sure that you're kind of bringing it back to the emergency action plan, but making sure you're having those conversations beforehand and you're closing those knowledge gaps so that when you do have conversations over an injured athlete as to how to treat them, everybody is rowing in the same direction.
Yeah. So
you're not busy.
No.
He sounds bored.
Yeah. That's why I came here today. I had so much free time.
Canceled 3 patients to come here.
Just squeeze them together. I didn't cancel anybody for this.
No, that's pretty cool. And, we know that you personally and members of your team are at all of the, we see at all these big events. And, the most recent that I was involved in was, of course, the marathon. Mm-hmm. You guys are all over the place.
Yeah.
So.
And that's what we do. So it's not just football season. We are at every event, and so we might, whether it's us, whether it's the athletic trainers, whether it's the coaches, it's all people that create this team of healthcare professionals that take care of the athletes, and it really is a collaborative effort. I'm learning from the athletic trainer's learning from me, I'm learning from EMT, and so we want to make sure that we keep that up. There's no hierarchy here.
Right.
We try to make sure that it's collaborative and everybody gets along, and we learn. We want to push each other to make sure that we're doing the right thing by the athlete, because that's really what this is all about.
Yeah, and then, I've got a bullet point here about, UH's commitment, so I assume that commitment is what got you here to begin with. So let's talk a little bit about that, and then we're building this monster over in Beechwood.
It's an amazing facility.
Yeah, at Ahuja, right?
At Ahuja, the Drusinsky Sports Medicine Institute, the second phase of the Ahuja build-out. It's just, it opened last week, partnership with T3, doing all of the performance training out of there. We've got a 45-yard football field inside, turf field inside that we can use, capped off with a basketball court. We've got a ballet bar. I'm sure there's a word for it that I don't know that I'm blanking on right now, but the mirrors in the ballet bar, in addition to state-of-the-art rehab facilities, everything that you could possibly want in a physical therapy group is there, from underwater treadmills to the latest equipment to, the top flight physical therapists that are going to work with the same athletes, or the same physical therapists are going to work with your kids, your youth athletes as do with the Browns and the professional athletes. So you may see somebody there rehabbing that's a professional ballet dancer, or a professional hockey player, a professional football player, and your kids are working with the same people.
Working on the same people.
Yeah,
that's cool, and that's part of the community class care that UH does, right?
Absolutely.
That's really cool. It looks sharp from the highway.
It looks fantastic. It really does. And inside is just as good. I mean, if
I haven't
you go
been in
in
there yet, but
the second floor is where the clinic space is, where we see patients, and from there it's like you're in a skybox looking down at the field. So everything's glass. I know it's all glass from the outside, but even on the inside, when you're up in the waiting room, you're looking down, or if your kids are there rehabbing, you can watch them from up above and sit, relax. You can watch from down below. Everything is really set up like you're at a professional, professional event, so that you can see everything that's going on.
That's really cool. Is there a pool there?
It's not a full-size pool. There's an underwater treadmill that is in a small pool.
Yeah.
Not enough to. I mean, I could do laps and maybe set some records, but that's about it. You can touch both walls from being in it.
Yeah, I get it.
But no, it's more for the underwater treadmill.
Yeah, for the rehab stuff.
Sounds like we need a VIP tour.
I think we need to get over there. No, I said it really does look sharp. So I'm glad we're investing in that, and so moving on a little bit. Let's talk about the planning for these events on the professional side.
Sure.
It's kind of, I guess we can draw some parallels to the local, but there's some stuff we definitely need to harp on with the local that's our providers and our admins that may be watching this really need to focus on. But from the pro level planning, what kind of stuff goes into that?
Yeah, and what we're really trying to do is take those lessons that we learn at the professional level and scale them back down to the high school level, so that we can take those things that are imperative whenever you're figuring out what your emergency action plans are, how you're communicating, all of those things. We want to make sure that we're doing very similar things. The difference is at the professional level, we have the equivalent of a small hospital on the sideline. We have upwards of 30 medical professionals on the sideline, and so trying to coordinate all of them is a bit of an undertaking, and that's really where we rely on our athletic trainers and our head team physician, head medical physicians to make sure that there's communication. And we get together and we practice it. And you would think that if we are going to practice it, it's going to be pretty similar year after year. We've got our emergency action plans, but there should be a living, breathing document, right? It's not set in stone, and so it gets updated every year. And when we do that, we try to basically prepare for it. And so the way we prepare for it is everybody gets a copy of the emergency action plans. There's not just one. There's one for collapsed athlete. There's one for collapsed athlete, 2 rescuers. There's one for there's a pool there. So we've got a pool emergency action plan. We've got a mental health emergency action plan. We have a heat emergency action plan. So there's multiple emergency action plans. We all get it beforehand. We review it. Then we show up for practice. Everybody takes time out of their day. And I will tell my athletic trainers the same thing. If your stakeholders can't get there to review your emergency action plans and actually practice them, take a couple hours of their day, then you're sending your athletes to the wrong people, right? If you want to take care of our athletes, you have to be here to practice that emergency action plan. Whether that's the squad that's going to be showing up on Friday nights, if they can't be bothered to take a couple of hours out, then you need a different company doing that, right? Yeah. If you've got a doc that can't take a couple of hours out of their office hours to come and practice the emergency, you need a different doctor. And same thing for the schools. If their athletic trainer isn't doing their job and setting this up, you need a different athletic trainer.
You need to switch gears, yeah.
Right. So we want to make sure that we are practicing it. So we're there a couple hours. We do it both at the stadium and at the facility in Berea. So that because it's different structures, there's different roadblocks, and that's each venue has its own unique set of circumstances that you've got to deal with every year. And then we review it at the end, and so it's evaluating it at the end where we go and we change what we need to change. And so whether that's new protocols, whether there's construction, whether there's a better way to do something, we want to make sure that it's up to date. And that's the same thing that we're doing at the high school level. That's getting everybody together, and it can be difficult. I've heard from a lot of athletic trainers trying to find that time, but I think with what you saw in Cincinnati in January with DeMar Hamlin, that practiced, rehearsed, coordinated effort led to the best possible outcome in an absolutely terrible situation, and really when you're looking at it from the professional side, the most difficult situation, because it is an away team player and that away team medical staff is relying on the fact that because you can't take people from Buffalo and go practice in Cincinnati and go practice in all the different cities that you're going to play in that year. It's just not feasible. So you're relying on the fact that the home team has practiced their emergency action plan, that they've got it together, they have it down, and that's exactly what happened there, right? And it's kudos to them for putting in the work, and everybody across the league. And I think I can speak for the NFL because I've seen it, but I'm sure all of the professional leagues do the same thing. The goal is to try to do the same thing at the youth level, and that can be difficult. If I send an email to a fire chief, or I've got my email signature line, assistant team physician for the Cleveland Browns, and that will get people there. Athletic trainers don't always have that, so you don't want it to take a tragedy, and that's, I think, some things that we'll talk about moving forward. We've seen this happen before, and yet we're still talking about it. We saw it back in we saw it with Hank Gathers, we saw it with Chris Pronger, we saw it with Jay Bowmeister, we saw it with Corey Stringer. There are all these athletes that have had varying outcomes from this at a very high, very visible level, but we're still having these conversations about emergency action plans and making sure people are practicing and having all of these things there. I'm hopeful that the difference here is that, if you go back and look at Jay Bowmeister, that he collapsed during a hockey game. It was on live television, but maybe 200,000 people were watching that regional hockey game. This was a Monday night game in front of 21 million people at home. Everybody saw it. Everybody saw the outcome. I mean, it's one of those. I remember where I was when I remember where I was when the Challenger happened. I remember where I was when the towers were hit. Right? But this outcome and the generations before, I remember where I was when JFK got shot or assassinated.
Sure.
This has a positive outcome. He's back 6 months later playing football because of these steps that were taken beforehand, and hopefully we can continue to push that narrative. The NFL is doing that with the Smart Heart Coalition that they founded. Their 3 tenets are: make sure that you have a working AED, that is within 2 to 3 minutes of that athlete. You want to make sure that you have an emergency action plan that is rehearsed and updated yearly for each venue, not just for the school, and have multiple emergency action plans for all of those things that we talked about. And then finally, having hands-only CPR training and AED training for coaches and whoever else is around that team.
So you spoke a little bit about, at a professional level, there might be upwards of 30 providers. What is that when you slice that up? What's the kind of providers are we talking about? Paramedics, EMTs,
all of it.
What specialties of doctors are in there? What do you?
Sure.
What's a normal complement? Let's say for an NFL game. Right?
Yeah. So from an NFL standpoint, we've got most teams will have 4 team physicians. You have the lead medical. You have the lead physician. that lead physician is either going to be the lead medical or lead orthopedic surgeon. And then you have the opposite, right? So if you've got a lead medical, you have a lead orthopedic surgeon. You've got assistant medical, assistant orthopedic surgeon.
Okay.
Then you're going to have on the home sideline, you're going to have a independent neuroconsultant who is usually a neurologist or a neurosurgeon. They're looking at concussions and making sure that the head injuries are being evaluated. In addition to that, you're going to have the airway management physician, which they're changing the name to now, but last year it was the AMP, airway management physician, AMP. On the visiting team, you have their complement of primary care and orthopedic surgeons, so they've got 4 there, plus an additional, what we called the VTML, which was the visiting team medical liaison, in addition to another independent neuroconsultant. On the far side, you've got, 2 athletic trainers that are up in the booth as the eye in the sky.
Sure.
Then you've got a couple of crews of ambulance, EMTs that are there on the sidelines. So, all told, you're 20 to 30 people deep.
It's a huge team.
Yeah, so it's a huge team. And all of us are there, at least from the home team side, practicing those twice a year.
Then the airway person, what specialty is that? Is that anesthesia? Is that EM? Who usually fills that role?
In the past, it's been either an emergency room physician or anesthesia. Moving forward, it's going to be an emergency room physician.
Oh, excuse me. Yeah. It makes sense, right?
Right.
Yeah.
Yep.
It's part of their specialty, right?
Right.
Yeah.
And then, the other team's doctors, do you run into any issues with them practicing across state lines or anything like that? How does all that suss out with, like if they come, somebody comes to Cleveland, right, with their cadre of people?
So, no. The short answer to that is no. And there's a bill that was passed at the national level that basically says, without getting into the weeds too much with it, basically says the locker room and the sideline are part of whatever state they're from.
Oh, that's fantastic.
Right.
Okay.
So that gets them out of that. And then the visiting team medical liaison, if they need a prescription filled or if they're sending the athlete to the hospital, that visiting team medical liaison will facilitate that, whether it's getting a prescription,
Locally,
whether that's, they have those connections as getting them to the hospital, talking to the accepting physician at the emergency room, transfer desk, whatever you need to do to get that player taken care of quickly so that they can get them taken care of.
Yeah, that makes sense. All right. Yeah. No, that's cool. I didn't know that, they had...
That's a good question. Like, how does their license move from state to
segmented,
state?
Right. I know, as a paramedic, I can't run across the state line and start doing stuff in Pennsylvania, right?
Yeah.
Exactly.
All kinds of questions there. So,